Hi, my name's James and I'm an expert by experience in eating disorders, which means that I have my own experience of anorexia and bulimia, and I use that experience as my source of evidence in the work that I do across policy, research and practice for supporting people with eating disorders. So the first thing to say is that my own experiences, of course, are only my own, and it's not the case that everybody shares the same experience. That is the beauty and the complexity of it. So I'm not speaking for everybody. And of course, it means that some of the things I might talk about, because I will refer to my own experience and some examples, might be difficult to hear, especially if you have your own experiences of eating disorders or similar. So do take care, do stop if you need to. And in the UK, I can recommend BEAT, the Eating Disorders Charity, First Steps, another charity, and a couple of other sources of support and information, which I put below this video. A few links are underneath. So today I'm talking about diagnostic overshadowing and eating disorders. Now, first of all, what on earth does that term mean? Diagnostic overshadowing is quite easy to understand, really, and I'm going to do my best to bring it to life. But also thinking about, well, why does it matter in terms of eating disorders? And what can we do to overcome some of the challenges that are presented in real people's lives and their experiences of care by diagnostic overshadowing? So I'm going to do my best, first of all, to say what it is. And I'm going to use some really bad metaphors. So the first idea I'm going to go for off the top of my head is fire. And I am a firefighter and I'm getting some incoming information of something is on fire, and I can see this video of it and I'm like, okay, I need to do something. I need to go and put out that fire. And what I don't see on that video is that there is some undetectable gas in the air that is feeding that fire. What I don't see is that it's pretty windy and there's oxygen fanning the flames of this fire. And what I do see is that, there's something urgent, there's a problem, and I need to sort of address it. And fire is that problem, not necessarily the underlying causes. So another example, let me think, a flood at the bottom of a stream or a river, gushing water everywhere, things getting submerged. And what you don't see there is that further upstream, there is a glacier which is melting because of factors halfway around the world that are causing the temperatures to rise there higher than they were before, and so it's unexpected. What you don't see is because there's pollution, there are little particles that are making the ice break down faster. I mean, do not quote me on that because it could be completely wrong, physics or geography or whatever it is, not my forte. But you get my idea. You see the alarming end product. You see this surface level problem which is causing damage, which does need to be attended to, but you don't necessarily understand what are all the driving forces. And you might, if you have your own experiences, or you might be putting the pieces together already, realise that this happens in people's care when there are symptoms that of course need to be addressed, especially if they're really urgent or life-threatening. But what also needs to happen is for the underlying and driving factors to be understood, to be comprehended, and perhaps responded to as well. Otherwise, you might get into just the continual putting out of the flames, or the continual buckets of water being, scooped out and continually refilling. And I think that this is definitely a problem that we have in mental health across the board. And it comes down to things like not having enough funds and resources to pay attention to what's happening earlier on. So another example, I'll go for size and scale. Yeah, so we've had this idea of urgency and something is wrong, but we don't really know why. What about size and scale? So there is Salisbury Cathedral in England. This is a really random example. It was once the tallest building in the world, and it is pretty awe-inspiring. I recommend it to anybody. But if it was stood right next to the Empire State Building or bigger, there's these huge skyscrapers of modern materials, you would probably be like, oh my goodness, that is huge. And what is this little toy church? Yeah. And actually, it might have some nice details. You might not be looking at the architecture or appreciating some of the tiny details that were carved into Salisbury Cathedral because you are really sort of overwhelmed by the sheer magnitude of this skyscraper. Similarly, when you're at a tourist site, you've probably seen it, that everybody is looking at the thing to be seen, the sights, we have to look at them, and not necessarily seeing what's going on around, like the pickpockets. And again, lived experience is the main source of evidence that I'm coming from with that. And you see what I mean here is that there are some things that we pay more attention to, we tend to, than others. And it could be because they are more compelling for urgency, for size and scale, or it could be that things are dwarfed and overlooked for reasons like ideas that we have. Yeah, so we might have an idea that is challenged by something, and so we don't want to look at it. Don't want to look at that thing that challenges our ideas. Doesn't fit into our stereotype, our typical idea, or what we think it should be like. And so, again, you might be resonating with that if you're somebody who doesn't fit into a neat formulation or stereotype or presentation, we might call it, of an eating disorder or any kind of medical problem, and you found it difficult for somebody to really consider that could even be a possibility for you because it just challenges the status quo. So there are many, many reasons why things are overshadowed, where the truth and the reality of a situation is not attended to because of ideas, because of urgency. And I'm not saying that these things are all wrong. Like, we do need a framework, we do need a sort of general evidence base, for example, and we do need to put out the fire in an emergency, rather than think, oh, was there something in your childhood that maybe caused that? I think that, you know, these things happen for very good reasons. But what I do think we also need to be doing is thinking about the whole picture and to really think seriously about, you know, what are the components that might not be seen here? And unfortunately, we are very visual and we think about presentations, you know, in medical terms, thinking how does something present on that quite surface level. And sometimes it's really just to do with resources. You have that 5-minute appointment, or the person isn't trained in all the different elements because healthcare is quite siloed, separated out into all these different areas. And there's somebody with an eating disorder, which is obviously a physical thing as well, because it's a behavioural thing. It affects, you know, major systems of the body, not just the mind, although of course I like to think the two are interlinked, not even interlinked, the same thing, or integrated. But the care that I've had for all those different components has been, you know, one clinic here, another clinic here, and not everybody is seeing the whole thing. And perhaps they don't need to, but maybe somebody in the picture really needs to, you know, or at least not overlook things that could be really important to the reality of that lived experience and might not be presenting in the presentation. So I think we need to rethink this idea of presentation and to look a little bit further. I can give another example actually, which doesn't actually link to eating disorders, though it does link to mental health a little bit. Of when I went to A&E not too long ago, about a year ago, with chest pain, kind of sudden chest pain. And I went and I looked, you know, fit young person, which everybody I saw was like, oh, you're a fit young person. Can't possibly have anything wrong with you, was the implication. And it took a really long time for people to see beyond the surface of this person looks well, therefore they are well, which is really not how medicine should work, to understand that there was something going on. And it was shown in my blood test results. But if I hadn't have pushed and stayed and really sort of said, you know, actually, this is not okay, I do need some help, then I might have been brushed off and that thing might not have been seen in my blood. And there is a really interesting mental health component, like I said, because I do look fit and well, but it does also say on my records that I have mental health problems. And so the explanation that I was given when I was there was, oh, are you not just a bit anxious? Like, you know, are you feeling chest pains, but just maybe imagining them because you're a little bit anxious, and our, you know, our chest can get tight and we can get palpitations and all this kind of physiological stuff going on, which is very much integrated, as I would say, with our mental health, with our psychology, but isn't automatically the case. This is an idea, you know, it's overshadowing the reality that no, something else really was going on. So I think this happens a lot in mental health in general, but I think it happens in particular, at least in my experience, which again is my source of reference here, in eating disorders. And we have a very clear distinction in how eating disorders services and treatment and diagnosis is divided up in terms of weight status. And it's so common, I hear it so many times, that people perhaps might have had anorexia and been very underweight, and then they put on weight during treatment and are suddenly considered to be well when that's not the reality of their experience. Their physical weight status, the way that they look, these are ideas, these are visuals, these are some things outweighing other things for whatever reasons, often sort of historical and outdated things that need to be really reformulated. But these outweigh or overshadow the actual reality for that person, which is really, I think, the main point of reference that people should be paying attention to, as well as the blood markers, as well as all these things that come from our evidence base and from our textbooks, and how we should, in theory, be treating people. It has to meet people with their actual experience, which should never be overlooked. I think when it is, it can feel really lonely. It can feel really like you don't know what's real because nobody else can see that or wants to pay attention to it or can comprehend it. So there are real risks, I think, of this diagnostic overshadowing. Things can be missed is the first one. So my experience, I had anorexia first and then I had bulimia. And when I moved from one to the other, I said to the clinicians I was seeing, I feel like I'm eating too much and being sick, and it's kind of this cycle that I'm getting into. And they said, oh, that's probably your anorexia talking. And so that shut down or overshadowed the reality of what was going on, which is that I was developing bulimia, by being told this thing that was based on an idea that, this is how anorexia works. It wasn't accurate theoretically, and it certainly didn't match with my lived experience. And like I said, one of the risks was that I then didn't want to talk about it again, that I didn't trust that my experience was real, that I didn't recognise that it was a problem because these experts didn't think that it was a problem, so I should just get on with my life and try and cope with illness as best as I possibly can. Other things, I was diagnosed with ADHD in my 30s, when it was really obvious in hindsight that it was hugely impacting my life from my teens, from my early teens at the latest. And it was never seen because I had really good grades. And there was this idea that overshadowed the reality that you can't possibly have good grades and have ADHD. You must be in the lower set. And no, you can absolutely achieve good grades with ADHD. Everybody is different. And that difference needs to be respected and attended to, not overshadowed by some kind of generic idea. And it was also overshadowed because there were much more urgent things going on. They were at a bigger scale, wreaking havoc on my life. I had an eating disorder. That was more of a risk to my actual life than ADHD and, struggling to sit in a classroom and pay attention and all of this kind of stuff that I was experiencing as well. So yes, there are good reasons why perhaps it was overlooked, but I think we can be a bit more ambitious and do both. We can see both and not just either or. And this is a central thing that I learnt in dialectical behaviour therapy, which was the therapy that I had that really helped me in the end with my eating disorder. This idea that one doesn't necessarily exclude the other is one that I'm so passionate about. You can both be in recovery and have a positive life. You can have ADHD and be very bright and achieve very well. It can be so difficult to hold these tensions, and we like to put things into neat little boxes, but the risk is that the person who is a complex mixture of all of these things doesn't have their own reality apprehended, doesn't have a response to meet their needs, and perhaps doesn't feel included. Another thing, I have Danlos Syndrome, which I'm going to do something here which might freak you out. I have very, very stretchy everything, and it's a connective tissue disorder which affects your collagen. I can't feel that when I do that. But because your connective tissue is your whole body, it has been involved in my eating disorder because my stomach is also very stretchy. It also has different problems perhaps than the average presentation. It's not like I'm presenting to the doctor and being like, hello, can you see this? But it was quite obvious. I have scarring in different ways on my skin than would be expected. I have lots of chronic pain, which was just put down to the eating disorder. And so many things were attributed to the eating disorder. Oh, your concentration, well, it's because you're not nourished. Well, when I gained weight and started eating and had a good nutritional status, it was still there. And so perhaps, that means it needs to be paid attention to, even if I can't pay attention to anything. It's probably some good joke in there somewhere. And with Danlos Syndrome, oh, this chronic pain is because you're not nourished. It's because you're underweight. Well, no, it's still there. And I think that these things are all interconnected. Like I said, it's not that the body is here and the mind is floating off over there somewhere. Actually, it is an integrated system. And so we need to have this approach when we're considering anybody's experience. It is so common that eating disorders co-occur with other conditions. Some people say comorbid conditions, which I just think sounds pretty awful. So I say co-occurring conditions. And it's so often that I hear stories of people like me who have other problems going on that are perhaps directly contributing to their eating disorder, but they do not get spotted until so late in the day that perhaps there's been damage done there that's been unseen. Perhaps there's been such a lack of quality of life as a result, and missed opportunities to provide effective treatment. For example, ADHD does feed into my eating disorder directly because I need stimulation all of the time. In the evening when I'm tired, one thing that I can do is eat. And that gives me lots of sensory stimulation. It gives me something physical to do, which is really important because I am hyperactive. So these things are not unrelated, but unfortunately we don't have enough experiences of care amongst people with eating disorders where there isn't this diagnostic overshadowing, and in fact everything is on the table or in the light, which is, you know, the counterbalance to diagnostic overshadowing is that whatever your diagnosis, there is still this capacity to shine the light of attention and awareness on different things that might be at play, and that has to be centered on the person's lived experience of their condition and the expert knowledge that can put together the pieces, because, you know, we can't do that ourselves necessarily as patients. And it was such a life-changing thing that happened to me when somebody spotted these underlying biological mechanisms and didn't just say, okay, this is the presenting patient. How do they fit this model that we have? How can we fit what fits into the model and let everything else be in the shadows? So that person just carries on struggling in the shadows like I did for so long. So I hope that helped to explain this idea of diagnostic overshadowing. It's a term that more and more people are hearing now, especially after, or still during really, the COVID pandemic, because many people with long COVID have used this term, diagnostic overshadowing, when going to ask for help for health conditions that aren't their long COVID, you know, there's something else going on, or they've experienced this problem that ideas about mental health can overshadow the realities that are going on physically. So, oh, it's all in your head, yeah? Which is great that we're paying more attention to what's going on in our heads. You know, that's great that we are more interested in that, but, you know, it shouldn't be just another way to write off somebody's experiences, perhaps of their embodied condition and the physical health problems that they really need help for. So I hope that video was helpful. I hope that it's something that brings to life this idea of diagnostic overshadowing. Some terrible metaphors in there, I can only apologise. And if you do need help, support, information about eating disorders, then I will be making more videos, but in the meantime there are links beneath this video. I don't really know what YouTubers say, is it? Hit the subscribe button and share and check back for new videos, and have a nice life.